We're standing here talking to the second author of a JACC paper, a meta-analysis reporting effects of angiotensin-converting enzyme inhibitors and angiotensin receptor blockers in patients without heart failure. And I'm here with Dr. Pierluigi Costanso, University of Hull, New York, in the UK. First off, what's the background of this paper that was in JACC? What were you looking for?
Well, actually, first of all, I'd like to point out that we did this paper in University of Naples and not in Hull. Anyway, we wanted to look to see if angiotensin receptor blockers are as effective as ACE inhibitors in patients who do not have left ventricular systolic dysfunction. So why this question? Because we know well that angiotensin receptor blockers work as effective as ACE inhibitors in people who have heart failure. Right. We didn't know about people without heart failure. So we actually collected data and performed meta-analysis, and we have found out that angiotensin receptor blockers basically are okay, but are not as effective in reducing all cardiovascular events in patients without left ventricular systolic dysfunction. And that doesn't mean that this class of drug is not good. It does mean that ACE inhibitors has been established to work really well in patients who have high risk of cardiovascular events. And angiotensin receptor blockers are still a good alternative in case ACE inhibitors don't work or because of side effects. So that's the bottom line, basically, of our research, really.
So the patients you were looking at, would you say these were patients with heart failure with preserved ejection fraction?
Well, actually, we excluded patients with heart failure and that were preserved, really. So we only looked in patients who didn't have any heart failure as such or any left ventricular systolic dysfunction, really.
At high risk?
But they were at high risk, and as high risk, I mean, ischemic heart disease, of course, hypertension and diabetes.
Which would be level A, I believe, for the American Heart Association, ACC's pyramid, which is the pre-heart failure. When you finish this, then your bottom line message is ACE inhibitors still should be your preferred approach. If for whatever reason those don't work, or the patient doesn't respond, or has a cough, for example, then try an ARB, but ACE first.
Absolutely. I mean, also because it's cost effective, first of all, giving an ACE inhibitors, and but giving an angiotensin receptor blocker doesn't cause any harm, of course, and it's still effective, especially in reducing the risk of heart failure and new onset of type 2 diabetes, or a combined outcome of major cardiovascular events. But of course, as first line, the results point to the use of ACE inhibitors.
Okay. Dr. Pierluigi Costanso, whose paper is in JACC, and that's where you can find it for Cardiol Source World News. I'm Executive Editor Rick McGuire.